The osteoarthritis, or OA, is one of the most common joint disorders worldwide, especially affecting adults over 40. It leads to pain, stiffness, and reduced mobility, making daily activities challenging for millions. OA is not just about cartilage wear. It involves inflammation of the synovium, changes in subchondral bone, and even affects ligaments and fat pads around the knee. As the disease progresses, it can significantly impact quality of life and independence. While total knee replacement is an option for severe cases, most patients seek non-surgical treatments to manage symptoms and maintain function, especially in the early and moderate stages of OA. Platelet-rich plasma, or PRP, is an innovative treatment gaining attention for knee osteoarthritis. PRP is made from a patient's own blood, processed to concentrate platelets, which are rich in growth factors. These growth factors help modulate inflammation, stimulate cartilage cells, and promote tissue repair. Unlike traditional injections like corticosteroids or hyaluronic acid, PRP aims to address the underlying biology of OA, not just relieve symptoms. Because it's autologous, meaning it comes from the patient, PRP carries a low risk of immune reactions or disease transmission, making it a safe option for many. Injected into the knee joint, PRP releases a host of growth factors, such as TGF-beta, PDGF, IGF-1, and VEGF. These molecules help reduce inflammation, stimulate cartilage cells, and encourage the production of the extracellular matrix, the building blocks of healthy cartilage. This is different from corticosteroids, which mainly reduce pain and swelling, or hyaluronic acid, which acts as a lubricant. PRP's unique mechanism offers the potential for disease modification, not just symptom relief, making it an exciting option for those with knee OA. PRP is often compared to other injectable treatments like hyaluronic acid, HA, corticosteroids, and bone marrow aspirate concentrate (BMAC). Recent high-quality studies show that PRP provides better pain relief and functional improvement than both HA and corticosteroids. In fact, PRP's results are comparable to BMAC, another biologic therapy. While corticosteroids offer quick, short-term relief, PRP's benefits tend to last longer and may even slow disease progression. This makes PRP a strong contender among non-surgical options for knee OA. Multiple systematic reviews and meta-analyses have evaluated PRP's effectiveness for knee OA. For example, a 2023 review of 27 high-level studies found that PRP led to greater improvements in pain and function compared to HA and was on par with BMAC. Another meta-analysis showed that PRP, alone or combined with HA, provided the best pain and function scores at both short and long-term follow-up. These findings are consistent across various patient-reported outcome measures, reinforcing PRP's role as a leading non-surgical treatment for knee OA. Despite promising results, there are still important limitations in the PRP literature. Studies often differ in how PRP is prepared and administered, making it hard to compare results directly. There's also a lack of long-term data on whether PRP can truly slow or reverse joint damage. Outcome measures and follow-up periods vary widely, and most research focuses on short to mid-term results. These factors highlight the need for more standardized, high-quality studies to better define PRP's role in knee OA management. PRP can be prepared in two main forms: leukocyte-rich LRPRP, which contains more white blood cells, and leukocyte-poor LPPRP, which has most white cells removed. There's ongoing debate about which is better for knee OA. LRPRP may trigger a stronger early healing response, but it could also increase inflammation and pain. LPPRP is thought to be gentler on the joint. However, most clinical trials show no significant difference in pain relief or function between the two, and both are considered safe for use. PRP injections are generally safe, with most adverse events being mild and temporary, such as swelling or pain at the injection site. Serious complications are rare. Studies comparing LRPRP and LPPRP found no significant differences in the rate or severity of side effects. This safety profile makes PRP an attractive option for patients looking to avoid surgery or long-term medication use. One key factor in PRP's effectiveness is the concentration of platelets in the final product. Higher platelet concentrations are linked to better pain relief and improved function, as shown in several studies. Patients receiving high platelet PRP report greater and longer-lasting benefits compared to those with lower concentrations. However, preparation methods vary, and more research is needed to determine the optimal platelet dose for knee OA treatment. How many PRP injections are best? Recent evidence suggests that a series of 3 injections provides greater and more sustained pain relief than a single shot, without increasing the risk of side effects. 2 injections may not offer much more benefit than 1, but 3 seems to be the sweet spot for most patients. This approach helps maintain a higher concentration of growth factors in the joint over time, supporting ongoing healing and symptom control. PRP therapy has been tested in patients with varying degrees of knee OA, from early to advanced stages. Studies show that PRP improves pain and function across all severity levels, but the greatest benefits are seen in early and moderate OA. Even patients with more advanced disease can experience relief, though the improvements may be less dramatic. This makes PRP a versatile option for a wide range of OA patients. Not every patient is an ideal candidate for PRP. The best results are often seen in those with early to moderate OA who are motivated to avoid surgery and can afford the out-of-pocket costs, as insurance coverage is still limited. Patients should discuss their medical history, OA severity, and treatment goals with their healthcare provider to determine if PRP is a suitable option for them. One of the main barriers to PRP therapy is cost. Since insurance typically does not cover PRP for knee OA, patients often pay out of pocket, with prices ranging from $500 to $2,000 per injection. This can add up quickly, especially if a 3-injection protocol is recommended. Patients should weigh the potential benefits against the financial investment and consider all available treatment options. Major challenge in PRP research and clinical practice is the lack of standardized protocols. Studies differ in how PRP is prepared, the number of injections given, and how outcomes are measured. This makes it difficult to compare results and develop clear guidelines. Efforts are underway to create more uniform protocols, which will help clinicians and patients make more informed decisions about PRP therapy. While PRP shows promising short and mid-term results, there's still limited evidence on its long-term effectiveness. Most studies follow patients for up to 1 or 2 years, but it's not yet clear if PRP can delay or prevent the need for knee replacement surgery. More research is needed to determine whether PRP can truly modify the course of knee OA over the long haul. Major medical organizations remain cautious about recommending PRP for knee OA. The American College of Rheumatology and the Arthritis Foundation both note that evidence is still insufficient for formal endorsement, mainly due to variability in study quality and protocols. However, as more high-quality research emerges, these recommendations may evolve, especially if standardized protocols are adopted. Fully realize PRP's potential, future studies need to focus on standardizing preparation methods, dosing, and outcome measures. Large multicenter randomized controlled trials with long-term follow-up will be key to understanding PRP's true benefits and risks. Researchers are also exploring whether PRP can delay the need for knee replacement and how it might be combined with other therapies for even better results. Real-world practice, clinicians often use a 3-injection protocol spaced 1 to 4 weeks apart, based on current evidence. They monitor patient progress using validated outcome measures and adjust treatment plans as needed. While PRP is not a cure for OA, it offers a valuable option for patients seeking to manage pain and improve function without surgery. Many patients report significant improvements in pain and mobility after PRP injections, especially those with early or moderate OA. Some experience only mild, temporary discomfort after the procedure, while others notice benefits within weeks. However, responses can vary, and not everyone will achieve the same level of relief. Setting realistic expectations and maintaining open communication with healthcare providers is important. PRP is often used alongside other non-surgical treatments, such as physical therapy, weight management, and oral medications. Combining therapies can help maximize pain relief and functional gains. Patients should work with their healthcare team to develop a comprehensive, individualized treatment plan that addresses all aspects of knee OA. In summary, platelet-rich plasma is a promising biologically active treatment for knee osteoarthritis, especially in early and moderate stages. It offers superior pain and function improvements compared to traditional injections, with a good safety profile. However, variability in protocols and limited long-term data mean more research is needed. For now, PRP stands as a valuable option for many patients, but should be considered as part of a broader, individualized approach to knee OA management.